Good day. I am Dr. Marc Ellis. I am the founder of the Georgia Chiropractic Neurology Center, or really my wife started to develop it in 1981, and I took over in 2002, but transformed it more from a biochemistry and nutrition office to a brain rehabilitation office. And I would like to talk to you this evening about some of our work regarding helping patients or people with pain and how we approach it. Generally, pain's broken down into peripheral pains and central pains, and we'll go through some different techniques that we use here for each one of those. One of the most interesting things about pain is that it's not really how we think of it. So when we look at the International Association for the Study of Pain, the way that they define it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So what does that really mean? Well, what it means is that there's actually no sensory stimuli that all people perceive as pain. With other sensations like light touch, deep touch, vibration, different temperatures, everybody's going to feel it that way. So if you put vibration on, they'll say, oh, that's vibration. If you do a certain type of touch, they'll say, oh, that's you're pressing. But with pain, one person can have a very small injury and they can perceive it as an enormous amount of pain and suffering. And another person could have a very dramatic injury, broken bones, all sorts of things, and not necessarily feel that much pain with it. So we have to look at that and say, well, what's going on? Well, there are not actually nerves in your body specifically for pain. There's nerves called nociceptors. They measure tissue damage, but they don't have to be pain. So when we look at the different sensations that we have sight, sound, smell, taste, and touch. And then inside of touch and things, there's actually more senses. So you'll have here your vision, olfactory, taste, sound, but then there's tactile, there's proprioception, which is information from nerves that are embedded around muscles or inside of joints. There's vestibular. So vestibular is coming from your inner ear. And then there's interoception, which is really, really exciting. And that's about nerves that are around your organs or around blood vessels. And they actually have a profound effect on us. So there's actually more sensory systems than we often think. And I really like this. This is called the dynamic self model. What happens here is that the blue is unisensory, the yellow is multisensory, and then the purple is you eventually end up making a picture of yourself. So when you feel something touching you and you hear a certain noise, your brain has to take the one sensation of something touching you, unisensory, and the one sensation of the noise, unisensory, and then it combines it into a multisensory experience, and then actually eventually you end up forming your own perception of yourself. And what's really, really cool is that you actually rewire your own brain sensitivity to different stimuli so that you can increase your perception of something or decrease your perception of something. So let's say that you're walking down the street and you think that you hear your dog coming. And so you hear this noise. Well, you'll increase the sensitivity to that sound so that you could pick up your dog and you would, be all excited and you're like, oh, there's my dog. And then you would find your dog and it would work out great. So you can actually increase or decrease certain sounds you want to hear. Or if you're walking down the street trying to look for your dog, you might not want to hear necessarily a conversation that's going on. So you can downregulate the conversation and upregulate the sounds that you're looking for, say, your dog. But with pain, what can happen is as you become more and more sensitized to pain, you can actually upregulate your sensations of pain. So let's say that you just naturally were going to touch something and you were concerned it was hot. Well, you would tell your brain, hey, I really want to pay attention to things that are hot, and you would become more sensitive to it. You would know that something's hot even before you touch it. But maybe if you weren't paying attention and you were cooking and you just touched the stove, you would be surprised, like, oh, wow, that's hot. So again, it's another example of how you upregulate and downregulate, but you can actually upregulate your perceptions of pain or your perceptions of nociception, and you can become hypersensitized to these sensations, and they can become more and more threatening to you, and it becomes a very difficult loop to escape unless somebody knows how to help you escape it. So when we look here at the skin and we say, all right, here's the skin, and then there's different types of nerve receptors. So these would say be Merkel's corpuscles, Pacinian corpuscle, Meissner's corpuscles, actually, Ruffini. So each one is a little bit different. You can see the picture makes it show different. So some give you highly sensitized perceptions of where something sharp may have touched you, and others spread it out and it becomes broad. So some people might feel very sharp, sensitized pains, and then other people feel more diffuse, burning, achy pains. And if we look over here, these are all different types of nerves, and they do things. So some do deep pressure, some do prickly, some do achy pain, some do sharp pain, some do like this muscle tendon senses the pressure on your tendon. So, and what it does is when you put too much pressure on your tendon, it would make your muscle weak. So if you think you're going to go lift something that's, say, 10 pounds, and you go to lift it and it really weighs 1,000, your muscle would become weak. That's what this nerve generally helps you to do. Unless something happens and, say, something you really love stuck under a car, you could actually pick that whole car up and you could override the nerve input and save the thing that you care about. Those are, you see that where women, something happens to their child and they have this superhuman strength. It doesn't mean that they don't get injured to do it, but they're able to override their nervous system or change the way that they're responding to their nervous system. So this is a very important thing, because sometimes our nervous system gets locked into unpleasant experiences and we need to change it so that we can get back to good experiences. And you have to know how to do that for a person, but it's possible to do it. A lot of times people will focus in on the one area where they hurt and they might not know all the other possibilities of what it can be. And here at Georgia Chiropractic Neurology Center, we work very diligently to try to understand all the different possibilities and how they work together. So I'm a founding member of the International Fascial Research Congress, and I designed what is the first ever fascial scar tissue adhesion model. So I was just showing it around at our Congress, and everyone agreed they hadn't seen one of these before. So this is a leg, and this is the skin, and there's some scar tissue that's in the skin. I'll show you later. These are muscles, and there's a piece of scar tissue here or here. Some of the muscles are white, some are red. It just is how the model functions. And then we have tendons and joints. And each one of these sections ends up having a different activity. So when we look at this picture, what's the point of this picture? It's muscles in motion. And everybody thinks that muscles are really what are moving us, and muscle is where everything's at. And we think in terms of muscles very dominantly in this society. But as a founding member of the Fascial Research Society, we think that there's a more complete picture. So in the 1500s, people were making, say, these anatomy pictures. And you can see here, this is fascia. This is the connective tissue around your body. So there's different fascias or different tendons or different forms of connective tissue all around your body. And what they used to think was that it was almost inert. It's, you see here, it's like dehumanized. It doesn't matter. And what's really human is the muscles, and everybody would learn the muscles. Or here in this plastinate from Germany, you see, hey, look, here's the muscles. But what the Fascia Congress did is they said, no, we really want to understand the fascia more. So this is your pericardium. This is the fascia around your heart, and you can see how it blends into your diaphragm and how breathing becomes fundamental to heart health, not just because of oxygenating, but because of the way the muscles are pulling on the connective tissue and actually changing the connective tissue and changing the fluid. And they went through and they made a whole plastination that demonstrates different aspects of the importance of this connective tissue. Inside of your connective tissue is where your nerves are embedded, and different nerves are embedded in different parts of the connective tissue. So some are in the skin. Look at the amount in the skin, a huge amount in the skin. This is subcutaneous tissue. So in this picture here, you can see that this is different subcutaneous tissue, and I designed it so that there's different layers. And then there's superficial fascia, deep adipose, deep fascia, which would be down at this level, and it has different nerves than muscles. There's not a nerve inside of a muscle cell, but around every muscle cell is fascia, and it has names like epimysium, perimysium, endomysium. So we've named all these different connective tissues that go around the muscles, and embedded in it are nerves that help perceive muscle movements. Then there's ligaments, joint capsules, and tendons. So each one of these has a different function. And as a doctor that specializes in helping people to relieve the pain, what you want to be able to do is you want to try to figure out which level is the problem at. So a lot of times patients, let's say with low back pain or herniated discs, will have pain, and they'll go get an MRI and they'll see that the disc's herniated, and they'll say, oh, well, that's your problem. You have this herniated disc. But they didn't palpate around and feel the skin or ligaments or connective tissue, or evaluate to see if you have a central pain where it's just coming from your brain. One of the ways to have a pretty good idea that you have a central pain syndrome with low back pain is if you go along and you take a cortisone injection or something and it doesn't really work at all, then you probably have a central pain. You probably don't have a peripheral pain at all. And I know a lot of people will keep trying more and more meds to get better, but they probably have a central pain syndrome. And that's where, as chiropractic neurologists, we do really well with central pain syndromes. But also in my system, we're very good at working with the different pain in all the different tissues because of my background with soft tissue work. So here you can see that this is the skin. And when you look at the skin, there's the outer skin, which is this blue area. Then there's some adipose tissue here with fascia around it. Then this red layer is more connective tissue, then more adipose with fascia, and then another connective tissue. And on here, I made this line through it, which is a scar. So that's here on the model. There's this scar. And what happens is the scar could go all the way through and go all the way down to your muscle, or you could have this scar here, if you can see that, where it doesn't go all the way down to your muscle. So when you look at these scars, what they can do is they can alter your skin, and they can alter the way that your brain feels your skin. So sometimes there's, what you saw earlier, there's a lot of nerves in this area, and you can have your pain generator just in your skin. So you have to know how to go into the skin and feel. I designed this picture, which is a picture showing how scar tissue can be down here, say around muscles or in the fascia and muscles, or it can go up into the hypodermis and it can go up into these different areas, or here it's not going all the way up, it's just on the bottom layer. So you have these different layers and different types of connective tissue in the layers, and then the scar tissue can move through in different areas, and you want to have a very precise skill set to work to feel these, and then you push on them and the person will say, oh wow, that hurts. Now if it's in the skin here, let's say, or here, let's say here on your shoulder, and you're pushing down on your shoulder, well, a lot of people will think it's their muscle, but when you push down on that, you're pushing on the skin first. So instead of pushing down on it, what you have to do is you have to pinch the skin like this, and you have to roll the skin, and you have to know how to roll the different layers. So if you just push down, you might not know if it's skin or muscle or tendon. So here you bring it up and you feel the different layers, and pulling one direction would pull your skin one way, but pulling a different direction on the same area, you can see here with these arrows, this arrow would pull this line of connective tissue, and this arrow would pull this line of connective tissue. And they're different, so you have to actually feel which little vector it is, and then you can do techniques to help it. So that can be pain from the skin. Now your skin, input from your skin, is considered as powerful, if not more powerful, for how you move than input from your joints and your muscles. So people don't necessarily realize it, but they keep hurting their muscles, and they might be hurting their muscles because they're not reacting to their skin moving correctly, and then there's reflexes from your skin that go into your central nervous system and cause you to move your muscles wrong. So one more time, you can have chronic tendon injuries or tears, but they're coming from the fact that you have adhesions in your skin and you don't feel them right, and you haven't had them treated, and when those adhesions are moving, they're sending messages into your brain, and your brain's misinterpreting your movement, so you move your muscle wrong, so you chronically injure it. And you got to know how to look at that, and then you got to know how to fix it. And if you do it, it's really helpful. So it gets a little complicated because things start to layer, because then you still have to fix the muscle, or you still have to fix the tendon. So let's look at another one. These are trigger points. And I graduated massage school in 1997, and I had 3 certifications. One was sports chiropractic, one was Swedish, which interestingly enough was originally a sports technique, and the other one was neuromuscular therapy. And neuromuscular therapists do a lot of work with what are called trigger points. Now, it was developed primarily by an osteopath, Travell and Simmons, or a chiropractor. It was never actually supposed to make it into the massage world, but they learned it and then they kept utilizing it, and I think really excelled at it. So I'm a neuromuscular therapist, and what we do is we look through and we find these trigger points. So, and then the trigger points have referral patterns. So here, this muscle in your neck refers up into your head, or here, a certain area of your traps can refer up and into your head. So a lot of times people have chronic headaches, but it's actually from trigger points, and people don't look here on the neck to see if they have a trigger point. So these are called myotogenous referrals. Now, the real classic referral that everyone's used to are this. So here, if you have a heart problem, then you'll frequently get pain that goes down your arm, or a lot of times for women, it'll go up into their jaw. And so these are called viscerosomatic reflexes. So if you're familiar with that, like, oh, you have a heart problem, you feel it in your arm. Well, trigger points are like the same thing, where if you have a trigger point here, it causes pain somewhere else. So these are very important to be able to feel and to know how to fix in order to help people relieve the pain. And again, some of them are interesting. Like there's one under your arm, and it's called subscapularis, and it causes pain in your wrist. But you see, once your wrist hurts, then you can keep moving your wrist wrong and injure your wrist and get carpal tunnel. So one, subscapularis is commonly causes wrist pain that some people think is carpal tunnel. Or two, you could have a subscapularis trigger point that actually makes your wrist hurt. So then when you're working, your wrist is hurting, and you can move your wrist wrong and actually get carpal tunnel. But it's hard to fix the carpal tunnel because you have to go fix up in your shoulder, up here in your shoulder at this trigger point to fix the wrist. And you got to know kind of how to check that. So that's pretty important. And we do that here at our office. So now when you look at visceral referral pain is pretty cool and often overlooked. So one of the things that you can do is you can do visceral massage. So visceral referral pain is like we're talking. So here's your heart, and it sends messages into your spinal cord and up to your brain. And the way it works is the muscles from your heart share this common pathway with muscles from your arm. And so as the muscle from your heart comes in and the muscle from your arm comes in, it goes over and it goes up to your brain. And then your brain can't interpret which one's hurting, the heart or the arm. Well, that's the same thing with the trigger point. It can't interpret what's hurting, the muscle under your armpit or your wrist. And so for visceral referral pains, we're able to look at that and work to get those better. So this is the same. Visceral referral pain is a type of pain that originates from internal organs and is perceived in a different area of the body. It occurs, so this picture here should show this, it occurs when sensory signals from an organ travel along the same pathway as pain signals from skin, muscles, causing pain to be felt in an unrelated area. So you can see here the viscera comes in and it meets with the skin and they share information. Or it can meet with the muscle and share information. So like people who have problems with their gallbladder frequently get right shoulder pain. And they could actually hurt their shoulder because it's sharing the information from the organ and the muscle, and you could injure the muscle. So, but you can go in there and do visceral manipulation and do massage for the organs, and you can improve the organ health. Now, how important is this? Well, it's pretty interesting. This sensation is called interoception. So interoception is this feeling of your organs or your blood vessels, and these are the pathways that it links to. So it goes to your brain stem, which is all like breathing and organ function. It makes sense, right? The information from your organs goes to the part of your brain that controls your organs, like your brain stem, and your hypothalamus, which is emitting hormones and things to help you sleep cycle and your health and things. And then it goes up into some other areas, and a lot of these areas are related to your emotional brain and to intuition and trusting yourself. So self-efficiency predictions, right? And things like that. So it's related to how well are you doing? Well, if your organ systems don't work well, then it's related to how well am I doing? And people can get anxious and not trust themselves. So they can get chronic visceral pain, addictions, different neurological, psychiatric disorders, neurodegenerative. Autism is associated with these types of things, pelvic disorders, arthritis, and a variety of different comorbid conditions. And so This comes out of this journal, Diseases, Disorders, and Comorbidities for Interoception. So these are really important aspects, and if you know how to go in and look at it, then you get a better result with helping people. So another one is a nerve pain. And what you can have is you can have different nerves in your body. Some nerves are more for motor and some nerves are more for sensory. And the nerves can get entrapped at different areas, like your sciatic nerve, it can get entrapped. But when you look at sciatica, and it can be a disc injury, or a lot of people are familiar with piriformis, but it can also be in the hamstrings, or you can have trigger points in different muscles in your leg that make you think you have sciatica, or you can have brain-based sciatica. And so what you want to be able to do is you want to know the pathways for the nerves, you want to know where they can get entrapped, and then you want to have techniques that can unentrap it. So what some doctors do is they do surgeries, and they go cut to take the connective tissue off the nerve. One more time. They do a surgery and they cut the person to get the connective tissue or the scar tissue to come off of the nerve so that the nerve's able to slide and move correctly, and it helps it heal. But there's other ways that sometimes also work with soft tissue mobilization, where you just use your hand and you just do myofascial techniques in order to improve the viscosity of the tissues around the nerves, and you're able to let the nerves slide and glide and move again, and then the person heals, because we're designed to heal. It's just sometimes we need some help. So one of the other things we do here is we look at peripheral nerve entrapments, and we're able to do different techniques to help improve the person so that the peripheral nerve entrapment's not there. You can also have pain with your joints. Now, fortunately, our doctors are chiropractors. So as chiropractors, we're experts at helping people heal from problems with joints. And we're trained to do every joint in the body. And there's a few we don't do, like some things in your nose or something, but basically we're doing the majority of the joints in your body. So we're doing your toes and your ankle and your foot and your knee or your wrist or your elbow. We don't specialize like, oh, we just do the foot. We can do all of them. So we're able to look and we're able to say, hey, you have a knee problem that's making your back not work right, so you have a back problem. Or you could have a knee problem because when you walk and you move your left leg forward, you would swing your right arm forward. That's the correct way to work. But if you have a knee problem on the left, you could end up with a shoulder problem on the right. So we're able to look at these complex interactions, and we're able to say, hey, you actually have this knee thing that might be related to your shoulder. And a lot of people will know it, particularly athletes. They'll go, oh yeah, if I'm pulling a certain way, I can't put my pressure on my knee because I'm not as strong as I want to be. So I'll bend differently to make myself strong. And that's how the body works. So we go through and we look at all the different joints, and we see how your joints are, and we're able to help with the joint. But a lot of times, just imagine if your joints are hurting, then what's around your joint? Well, joint capsules are around your joints, tendons are around your joints, ligaments are around your joints, muscles go around joints, skin goes around joints. So if the joint's hurting, you can have problems in any of these other areas, like muscles, tendons, ligaments, skin, all these other areas. And if you only do work to help the joint get better, and you don't do the other correlated synergistic parts of your human body, then the probability of fixing the person is lower. Now, here's the deal. This is really wild. The information from the different parts of your body send nerves into your nervous system. Some of them go to your spinal cord, and they actually make these maps. So like information from your hands in one area or your shoulders in another, or this is your cerebellum, and it has maps of you. And then up here is your cerebral cortex, and there's actually these maps of where the nerves go. So they would electrocute people during surgeries because the nerves in your brain don't actually have nociceptors in them. The blood vessels do. The fascia around your brain, like your meninges, also has nociceptors in it, but the brain itself doesn't. So they could electrocute the person and they would say, oh, I feel that in my hand, or oh, I feel that in my leg, and they were able to map out where the different nerves go. Now, if you have pain, so this represents your hand, and this is labeled 1, 2, 3, 4, 5, and then this is a little part of your brain. And here, your thumb goes to here, number 1, and your pointer finger goes to here, number 2, and your middle finger goes to number 3, your next finger 4, and your next finger 5. So this has 1, 2, 3, 4, 5 fingers that are represented in this part of the brain. But then what they're saying is, let's say that you amputate these fingers. What ends up happening is you don't lose those nerves in your brain, but instead they blend together. So now you have 1, 4, and 5. So here you go, 1, 2, 3, 4, 5. In this example, number 4 takes over. So the information from this part of your finger, you're feeling it over here. And so sometimes people get phantom limbs and they're feeling extra stuff because in this picture, you're seeing it kind of makes sense. Number 4 takes over for 2 and 3. But interestingly, let me see if I can go back. I can't. But interestingly, your face is also right next to your hands. So sometimes the information from your face ends up activating your hands. And so different activities with your head can make your hands feel funny. And these are called central pain syndromes. And there's a lot of different central pain syndromes. And what people don't realize is you don't have to lose your limb. You don't have to have phantom limb pain where you lose your limb, like you lose your arm, but your hand still hurts. But what can happen is you could hurt your hand and it actually rewires your brain like this, but then your hand heals, but your brain didn't heal. And so your brain's still telling you your hand's hurting when your hand isn't hurting. And there's a variety of different situations where this can occur. Unfortunately, a lot of people were ending up on opioids for these different central pain syndromes. So I was asked to go down to the Capitol here in Georgia, and so I went before the Georgia House of Representatives for the House Study Committee on Alternatives to Opioids. And I presented to that committee on chiropractic as a non-pharmacological alternative to opioids. And we had a lot of really good evidence. The American College of Physicians recommends to do chiropractic before opioids, or really before any med. The VA recommends it. The CDC recommends it. So we went down and we were talking about the research and the evidence that supports the utilization of chiropractic as an alternative to opioids, because we have a real challenge here. Well, one of the parts of the challenge is related to this central pain syndrome. And a central pain syndrome is pain that arises from dysfunction in the central nervous system without any peripheral nociceptive input. Or you could say, well, there used to be a nociceptive input, but it healed and it's still there. And so some of these things are fibromyalgia, chronic fatigue syndromes, migraines. Interestingly enough, there's general, I like to categorize headaches two ways, primary headaches and secondary headaches. Secondary headaches are like your blood sugar goes low and then you get a headache, or you have neck pain and you get a headache. Primary headaches are migraines, and migraines are all considered brain-based pain. So with the migraine, where are you hurting? In your brain. It's a central pain. Complex regional pain syndrome, for any of you who have that, you know how difficult it is. A lot of people's hands can change colors because their sympathetics get so high, but those are generally considered brain-based pains. And then AMPS, which is amplified musculoskeletal pain syndrome, and unfortunately more and more people are being diagnosed with AMPS. And so what happens is you can have a central pain, and the pathways with this are pretty well known. So here you have some sort of a receptor in your body, like we talked about different receptors, like a Pacini corpuscle or a nociceptor or a thermal receptor, and the information goes into your spinal cord, and then it travels upward through your brain, say to your cortex or limbic system's emotional, and this area is your brainstem, just different parts of your brainstem. So, by the way, I use this picture when I'm lecturing to doctors, so you don't need to know what all these things are, but it still is just helpful. So all these are different parts of your brainstem. And as the information goes up, your brain has these regulatory systems where it blocks the pain. So it can send chemicals and messages up here to block the pain at your higher brain center, or it activates these areas, which are in your brainstem. This is your para-aqueductal gray, and this sends serotonin down into your spinal cord. And so you can send messages either up or down to help filter the perceptions of pain through centrally based pain. Now, interestingly enough, let's say you have pain in the shoulder. It doesn't mean you have to treat the shoulder, because if we go back and we take a look at where we started, we say, well, there's all these different types of sensory systems: vision, smell, taste, organ systems, inner ear systems, proprioception, touch. And each one of these systems has on some level an interplay to one of the other systems. So here they come in unisensory, then they go multisensory, and then they help you to form yourself. So as the visual system's coming in, it can actually change your brain activity and change how you feel pain. Or smell can change how you feel pain. Or turning your head and rotating can change how you feel pain, because the touch system or the proprioceptive system or the nociceptors that are sending these messages in are interdependent on the other areas. So one of the other things that we do here is we have people come in and we do a pretty extensive examination where we have infrared cameras and we look at eye tracking systems, then we look at balance systems, we look at your heart rate, we look at blood pressure, we look at how you walk, how's your cognition. So you know that when people get depressed, their frontal lobes fire lower and they don't think as well. Your frontal lobes are the part of your brain that people talk about, oh, that's your thinking area. Or back here, your occipital lobe, we say, oh, well, that's your visual area. And so there's these different areas. Well, your frontal lobe, when it goes low, people get depressed, but what else do? They feel worse. They have more pain. They digest their food not as well, very frequently, and get chronic inflammation, or inflammation can cause the frontal lobe to go down. So when we're looking at your cognition, we're looking at your frontal lobe, but the frontal lobe can tell us how you're reacting to your own sensory system. And if we improve your frontal lobe, we very frequently improve your emotional state, and we very frequently improve a person's pain, especially if it was related to their frontal lobe being lower. Other people with central pain syndromes, it could be their vestibular system. So they could feel like nauseous and dizzy, and their body can become imbalanced, and the information from the inner ear goes to the brainstem, and then the brainstem has all this pain modulatory activity and stress modulatory activity. So by doing different exercises related to the vestibular system, we work to help a person get better with pain. Now, let's imagine that a person had a vestibular problem and sprained their ankle because their balance wasn't good. Well, you can't just do vestibular rehab for them. You also have to fix their sprained ankle. Or you might not be able to just do treatment on their ankle because they still have this imbalance and they keep walking on it funny and they keep irritating it. So what we work to do is we work to look at your central nervous system and we watch as many areas of it as we can. Your frontal lobe, your vestibular system, your emotional brain, your visual system. And we work to give you exercises to make sure your brain's healthy, but at the same time, then we look at the other areas. So as chiropractors, and we look at all the different joints that we can. So we'll look at your ankle joint and your talus and how it's moving. And then we also, from the myofascial perspective, are going to look at the fascia around your ankle and your joint capsule and your muscle and your tendon and your ligament. And then we're going to look at how organ functions are working to help with digestion and anxiety states. And we're going to try to do our best to develop a plan that helps you to get relief from your pain by looking at these areas. So again, muscles, tendons, ligaments, joints, fascia, skin, organ systems, blood vessels, peripheral nerves. Is there a nerve in your knee that's not working right, causing you an ankle problem? Then the central nerves. How's your spinal cord doing? How's your brainstem doing? How's your vestibular system doing? How's your visual system doing? How's your spatial awareness system doing? How's your emotional system doing? How's your frontal lobe system doing? And for each one of those, we also have ways that we're able to exercise people with different eye exercises or head turns, or we have 3D virtual reality machines where we can have people do different movement therapies to optimize their brain health. And through this rigorous multifactorial approach, we have found that we do a really great job at helping people to recover and get better. If you're interested and you want to know if we can help, you can give us a call, and we do free consults. So it's fine. It's a free consult. Some people do those free consults over the phone. Some people come in person. So either way, that works for you, and then that can help you to figure out if you think that you would be interested in what we have to offer, or you can just skip the consult and you can do an exam. And our first exam currently in September of 2025 takes about 3 hours. So it's really quite extensive, and we work to put together a full picture so we know how to help, and then we talk to you about what works for you, because our general approach is that if you would like our help, you're bringing us onto your team. And we're experts in what we do, but we're on your team. And so we will give you the information we have, and we'll share our ideas with you, and then you can let us know what works for you. So for some people, they might have to use an airplane to get in here, and so we have to see them a little bit more frequently. Some people are just right around the corner. They can get here in 10 minutes, so we're able to do a different approach for them. Or some people have to drive 3 or 4 hours to get here. And so for each different person, depending on what they have, we try to tailor a care plan for you that works for you, and work together cooperatively as a team, and even with other healthcare providers that you're working with. We try to work in a balanced way to help you to get back to being able to live the way that you want to live and enjoy the life that you want to enjoy. So if you found this helpful, we appreciate that. I think you can probably click a like, which is a new thing for me to ever say, and which is good. But and you can feel free to give us a call, and we'll be happy to talk to you. All right, thank you so much.